Thank you, everybody, for joining us today. We're really excited you have the opportunity to learn a little bit more about Zephyr valves. So this program is called Zephyr Valves 101 for severe COPD and emphysema. The goal of the program today is to provide you with an overview of Zephyr valves and see if they might be right for you. This program will last about 30 minutes, and at the end, we will have a Q&A. Dr. Kopis, you click the next slide for me real quick. Yeah. If you do have questions you'll have a toolbar somewhere on your screen, depending on your computer, that will have a Q&A button on it. Please click that and type in your question, and we'll get to those at the end. If you have issues with that, you can send us a chat or raise your hand, and we can kind of help you on the back end. We will be sending you a follow-up email after the program with the information that we cover today, so it'll kind of help you round out if you missed some things. Let's see. Go ahead, Dr. Kopis. Let's select the next one. Yeah, it's my pleasure and honor to introduce to you Dr. Lisa Kopis. She lives in San Antonio, Texas, where she works at the Pulmonary Critical Care and Sleep Medicine Consultants. Dr. Kopis is board certified in internal medicine, pulmonary medicine, and critical care medicine. Her areas of interest include critical care medicine, asthma, COPD, pleural disease, lung cancer, and ultrasonography. Dr. Kopis has been treating patients with Zephyr valves since 2019, and she was involved in the clinical trials for FDA approval. Dr. Kopis and her team have treated over 75 patients, and we are happy to have Dr. Kopis lead our program today. Dr. Kopis.
Thank you so much, Travis. I really appreciate your kind introduction, and I'll just make one quick correction in case anyone is gonna try to find me. I was born in San Antonio and love San Antonio, Texas, but I'm actually practicing now in Houston, Texas. So if there's anyone out there locally who is in Houston or nearby, feel free to look me up. But I love San Antonio and visit there all the time. Okay, so I am also honored to be asked by Pulmonx to discuss this very important treatment for COPD emphysema. And I have had a lot of experience with it, and I will tell you, I am a believer, and I base that both on real data from research that, as Travis had mentioned, I was a part of, and more importantly, patient after patient experience and outcomes in the real life of my practice. So again, I will answer any questions that you guys have. This is totally informal, and there's no question that is too basic, or if I say a word that's kind of medical language or something that you don't understand, please feel free to put those questions into the chat or into the question and answer function, and at the end I'll be happy to answer it, or someone on the team will. We all are just here to help you guys as patients, and we'll be happy to do that. Okay, so I'm gonna just run through some basic ideas about COPD and the valve. And here's our agenda, just to kind of keep us organized. So we're going to talk about why breathing is so difficult for severe COPD and emphysema. And it's really not that simple of a question, because a lot of times patients will come to me and say, I can't breathe, but my oxygen's good, or my oxygen's not good, and I want to know why. So there's many different facets to breathing and how our brain and bodies both sense difficulty breathing and respond to it. And so some of those responses actually are a part of the problem. So I want to talk to you about the basics of the valve, which is the Zephyr valve that we're talking about. I'm also going to talk about the benefits and the risks. I'm going to talk about the major adverse events that can happen with that. What we have to do to make sure that you're the right person for this procedure, I always tell people, it does no good to hammer in a screw. You have to have the right tool for the right problem. And so just because this may not work for you, that doesn't mean that something else would. So we just want to be able to get the right patients in our clinics to do this. How to find a doctor and schedule an evaluation. We'll talk a little bit about that. And of course, we'll have our live Q&A, and I have the whole team here to help me if I flub up. So feel free. Okay. So why is breathing so difficult for me? I think that's one of the hardest questions for doctors to help patients understand. Again, it's a really complex problem. The lung is not a simple organ, and we do lots of things to the lung that do not help it. And so the thing I'm going to talk about today is I'm going to focus on hyperinflation. If patients come in, even if they have COPD and they do not have hyperinflation, then this particular procedure and treatment is not going to be helpful. And so that's one of the first things that I, as an advanced bronchoscopist, has to figure out, is what I am doing to the patient going to actually help them? And so for this particular procedure, we want to make sure that all the patients have some degree of hyperinflation. And what is hyperinflation? So hyperinflation, if you can think of a balloon, is just that there is a part of your lung that gets hyperinflated. It gets bigger and bigger and bigger with air. And so air gets trapped in the damaged parts of your lungs. Why does that happen? Usually, in the case of COPD patients, it is due to smoking-related damage. So smoke enters the lungs, it damages a part or all of the lung, and destroys some of the tissue in there and creates these areas where air gets continually trapped in them. And what happens to the damaged part of the lung is it gets bigger and bigger. And as you can see on this little video, which I'll play for you in just a minute, it starts to take up more space. So in your rib cage, you have only a certain amount of real estate. And the bad part of the lung starts taking up more and more of that real estate, shoving the good part up into a smaller and smaller area, thus making that not work as well. So the good parts of your lung aren't working as well. The bad parts of your lung don't work either, and they take up a lot of space. It is like, I described it to a patient the other day. It's as if you kept a non-working refrigerator and you put it right up against your new refrigerator, and you can't open the new refrigerator door. So both of the refrigerators are not allowing you to have any kind of function. So the area in your lung, as it says here, becomes larger and larger, hyperinflated, and puts pressure also on the diaphragm. So the diaphragm is your major muscle that creates for ventilation and breathing. I'm gonna go ahead and play this little video here and you can see what I'm talking about. And the diaphragm is shoved down so that the ventilation or breathing in and out no longer is as effective. So you kind of have a triple problem. You have an area that doesn't work at all because it's damaged. The damaged area shoves the good area up so that you cannot use it either. And the diaphragm doesn't work. So this is what causes the shortness of breath. Okay, so what have we done in the past to treat COPD emphysema? Well, all of you probably have an inhaler or 2 or 5 that you use, if not nebulizers as well. So we give lots of medication for that. And it can help, but a lot of times it's not enough. So we also want to send patients for pulmonary rehab if possible. Pulmonary rehabilitation is one of the most important treatments for COPD emphysema. It gets patients out into an exercise situation where they're able to exercise with some supervision and given breathing techniques so that they can improve their stamina. Up until the Zephyr valve was put onto the market, we then moved all the way to these very invasive procedures. We actually can do lung volume reduction surgery. It achieves a similar effect as the Zephyr valve, but of course, with surgery, it's much more difficult to get through and recover from. And of course, then there's lung transplantation. COPD emphysema is a very common reason for lung transplantation. Now we have this really innovative means of doing treatment for advanced lung disease in the form of emphysema, and also be minimally invasive, certainly less invasive than lung volume reduction surgery or transplant. So here is a picture of one of our valves. They do come in several different sizes, but just to give you an idea, right next to the finger, you can see they are very small devices, which gives you an idea. All of the airways throughout your lungs are really not that big. So these would fit into the airway tubes that are in your lungs. So they are tiny. They're placed in your airways through a bronchoscope. Of course, you would have to be able to undergo bronchoscopy, and we do use full anesthesia for that. But our anesthesiologist and anyone in the country who does this procedure on a regular basis are very well trained to deal with patients with COPD emphysema. So it is considered a minimally invasive procedure, which means there is no cutting, incisions, sutures of that type that you would get with a traditional surgery. It does treat the hyperinflation caused by severe COPD emphysema. And well, how do they work? Okay, so anyone who's familiar with a one-way valve on any kind of machinery would be familiar with this type of concept. So the one-way valve allows the trapped air, which is in the more damaged part of the lungs, to exit out through the airways. But if air tries to come back in to refill that portion of the lung, it is blocked by the valve. And so over time, you get all of the air out of this very damaged part of the lung, shrinking it down and giving the good lung more room to actually ventilate, and also to improve that diaphragm flattening. You know, the muscle of the diaphragm has to be able to move. And so it puts less pressure on the diaphragm, also improving ventilation. So there are an average of 4 valves placed in the most diseased part of the lung. I've placed as few as 3, and as many as, I think, 8 is the most that I've ever placed. And everybody's anatomy is a little different, and so that's what helps. That's what determines what size and how many of the valves to place. The valves allow for the inflated diseased part of the lobe to deflate and gives the healthier parts of the lung space to function. And I think there's a video here too, so we'll just demonstrate that in cartoon form. So this is a bronchoscope going down into the lung. Of course, you're asleep under general anesthesia. We're placing these valves into each part of that, each airway that goes to that particular part of the lung. And as you can see, air can go out, but not back in. And then we'll just simulate what happens to the lung. You see it makes it much smaller, giving the good part of the lung more room. The diaphragm comes back up into its normal position so that it can ventilate better. All right, so a lot of procedures have been done with these valves, and by and large, they are safe and effective. They're definitely effective, and they're definitely safe. Okay, there are some adverse events, just like with any treatment, and I'll go over those. But if you can look here, there's over 25,000 patients that have been treated in the world, and this particular seal of approval over here on your right-hand side of the screen is called the gold seal, and it's evidence A, which is a very high rate of evidence proving that these are effective. And the gold update is something that is basically a conglomeration of doctors and researchers, et cetera, that deal only with COPD. And they give out every so often a set of guidelines for doctors to use in order to treat COPD. And so they've given it evidence A. It did receive FDA approval in 2018, so it is definitely time proven. This is something that's not just right out on the market. No one has any experience with it. There are those among us, like they were saying, who've done many patients. So what are the benefits of Zephyr valves? As you can see, being able to move your lung better and also expand the good or better parts of your lung, you'll have less shortness of breath. So that's been proven in the studies. You'll have more freedom. So when you can breathe, you're not so anxious about going out into the world and going shopping and so forth, and even stuff in your own home. You know, I have patients who are afraid to get out of bed before the procedure because they're really afraid of getting short of breath or being too far away from somewhere to sit down. And of course, you can get back into your hobbies and socializing and feel more confident when you're leaving home and just being able to live your life. So there are some risks involved, including worsening of COPD, especially right after the procedure. Sometimes you can cough up a little bit of blood because we're manipulating in airways that are fairly inflamed. There have been cases of pneumonia after these valves, and in rare cases, death from any one of those causes. The one I really want to talk about is a very common adverse event that happens fairly soon after the procedure. It is called a pneumothorax. Some people describe it as a collapsed lung, but I don't really like that terminology because collapsed lung is used to say all kinds of different problems with the lung. A pneumothorax is an actual tear in the lung. And what happens is when you tear the lung, then you have air leaking out of that tear. And the lung, just like a balloon, if you popped it, the lung will kind of shrink up. And our treatment for that is it can be watching it. The lung will heal with time, or you can put in a chest tube to kind of bring the lung back out into its fully inflated position. But we are, and it happens quite a bit after this procedure. I think a lot of patients are very nervous about it. And sometimes their primary pulmonologists are pretty nervous about it too, because it does happen in about a third of patients, and usually within the first 3 days. So here's what we do. Patient comes in for the procedure, and we always keep them in the hospital for 3 days because that's when most of these occurrences happen. And we watch you like a hawk. So you'll have chest x-rays, there'll be nurses asking you if you're short of breath or having any other symptoms like chest pain. And some of us keep patients fairly sedate, meaning we don't want you running around or doing any kind of real big exertion during that time. And if you have a pneumothorax, we can fix it. So we're not only experts in doing the procedure, but we are experts in dealing with this type of side effect or adverse event. So for us, it's not as scary of a thing, but it is something that everybody needs to know about. Okay, so how do you know if you're the right patient for this procedure? So a set of simple tests are required. We have to have some pulmonary function tests. That gives us a great idea of whether or not you're going to have the kind of hyperinflation that would be treated with this kind of procedure. We also then do a CT scan, and there's this Stratix report, which is just a name for what you're looking at on the screen. It is a computer generated and report that tells us a little bit about where or if we should place valves inside a patient's lungs. So I won't go over too much detail, but basically these are destruction scores is what I'm going to call them. It's the easiest way for my patients to understand. And the higher the score, the more destroyed the area is. So as you can see from this patient, he or she has lower parts of their lung here and here that are fairly destroyed. And so those areas are where we would target placing the valves. It also gives us an idea of whether or not there's air that is leaking or communicating between the good area and the bad area. If there is a lot of that communication going on, then we would not want to put valves in, because it would just keep refilling the same area that you're trying to deflate. We also have to do arterial blood gases in a lot of times in a lot of patients, and definitely a 6-minute walk test. So I'm going to talk about the echo and the perfusion scan in a second, but the 6-minute walk test is very important because it gives us an idea or helps us to determine whether a patient has a good stamina or has been able to keep up with their exercise, and their muscles would not be deconditioned. We really like, I know I am very, I'm pretty strict on having my patients attend a pulmonary rehab program, because if you do not have the muscle stamina or conditioning, even though you put in these valves, you may not have a satisfactory result afterwards. I kind of describe it like if you had an old Ford truck and you put in all the gas, but the carburetor, the engine doesn't work, it's still not going to run. And so you really have to have both components. You have to have the muscle conditioning and the putting in the valves to improve ventilation and reducing that hyperinflation. So pulmonary rehab is very important. Now, what if you don't have a pulmonary rehab program in your area? You know, they are not in rural areas usually. Well, there are online equivalents, and also sometimes I just give my patients a packet of exercises that I tell them to do, and then they can keep a diary, come back, do the walk test, and if they improve or do well on that, then we can proceed with this procedure. It also, because of the anesthesia risk, sometimes we ask for some cardiac testing, including an echocardiogram, and there are perfusion scans or CTs, other different kinds of CT scans that we sometimes use to help us to determine planning for the procedure. Okay. All right, so what criteria do we use? Well, you have to have COPD or emphysema. Sometimes I do get patients with other lung diseases. I did exactly have that the last week, where they come with the word Zephyr written on a piece of paper and they say, please, doc, help me. I've heard this helps so many people. And unfortunately, it does only work for severe COPD and emphysema. And then we really want people who have symptoms, you know, so you know, if you have symptoms such as you can't catch your breath, you know, you take your medicine, and it doesn't help as much as it used to. Those are the type of patients that we really want to consider doing this procedure on. And then patients with lower or low-ish pulmonary function tests. So that's just a number there that doctors will use to help determine if you're in the moderate/severe category. But again, these are only general criteria. So if you're saying, hey, I still want to know, I just want to know if these valves are right for me, please even go definitely to a Zephyr valve trained physician. Sometimes the pulmonologists out there who don't do Zephyr procedures are working on old knowledge, or they think of these valves as like a last ditch effort. That is not my criteria in any sense of the concept, because I have seen patients who have more on the moderate side be able to really get out and exercise and go run races or walk and mow the lawn and so forth. And then I've seen patients on the more severe category. They maybe will get up, they'll walk, they'll do the grocery store, they'll do that sort of thing. So I would say definitely see somebody who's actually done these procedures in order to determine if you are a candidate. Okay, so I don't know if I'm supposed to do this slide. I guess I am.
I can actually cover it for you.
Okay, I couldn't remember. Thank you so much.
Thank you so much, Dr. Kopis. That was incredible. You covered so much information.
Welcome.
So I'll cover this slide and then we'll jump into the Q&A. So if you're interested in learning more about, whether or not you're eligible or not, we do have an online locator search tool where you can enter in your city and you can find treatment centers near you. The really great thing on the screenshot you can see here in the image, we have all the information there. It'll pop up near you. And then you can also text the number to your phone. So it's easy to dial that. When you are calling this number, you are calling to make an appointment to schedule an evaluation. If you do have questions, however, we will be sharing a phone number. We'll go ahead and share it in chat where you can speak live to a Zephyr care team member, or we'll also share the number at the end of the slides. Most physicians listed on this locator do not require referral. However, there are some that do. So just make sure that when you do call, that might be one thing, but for the most part, you can just schedule your evaluation. All right, so then go ahead and move on to the next slide, please. And then Travis, if you want to go ahead and pause the presentation. So when we're doing the Q&A now, we can just see Dr. Kopis talking. We don't need to see this giant blue screen. All right, so let's see. The first question we have here is, how long do these valves last and are they replaced after a few years?
Oh, that's a great question. So the valves should last as long as you last. And there are some situations, usually early or on in after placement, where we might do what's called an adjustment. I do always tell my patients that because, it is they come back and they say, oh, I'm not quite getting the response that I thought I would. Or I tell them, hey, I think we can, based on imaging or based on, just some lack of improvement that I don't see in you, we may need to tweak this. So within a month or two, we, not always and not the majority for sure, but on an occasional patient, I can take them back, take one valve out, fix it a little bit, fix it, move it, put another one in, something like that. And so there are those types of situations. However, it's not like they wear out in 5 years. Once they're in, and they don't, which should not need replacing, say, like you would a tire.
Got it, thank you. This question is, will coughing loosen or dislodge the valves?
So amazingly, that only very, very, very rarely happens. I have had 2 valves that have been dislodged. One, the guy has one of my patients, he told me actually before he even as one of his, as the interview proceeded, he said, oh, by the way, I have this quirky thing where since I was a kid, I've had these really horrific sneezing attacks, and I sneeze harder than anyone I've ever met. And I was like, oh, that's interesting. And we talked about it, whether it could dislodge that. And I said, well, I don't know, maybe we can, give you more nasal spray or whatever. But anyway, he got into a sneezing fit and it came out. I ended up going back. We took him back into the OR and replaced the one that had come out. And he's had them in probably now 8 or 9 months and no other problems. And he says he sneezes, but nothing comes out. And I have had one coughed out. But again, I've put in, hundreds of valves when you count each individual valves in the different patients, and they generally don't come out.
Great, thank you. This question is, I was treated for non-small cell lung cancer. I was treated successfully and I've had no sign of cancer returning for 2 years now. Will the cancer prohibit me from the procedure?
So the question that I would ask is your oncologist or your thoracic surgeon or whoever is dealing with the imaging part of your surveillance for the lung cancer, they need to be comfortable with where we're putting the valves. And I'll give you a little bit of why. When we put in the valves, the part of that lung will shrink down, and it will be harder to detect recurrent cancer in that specific area. So for instance, if you had a right-sided lung cancer that was treated with radiation or chemo or whatever, and you've been, out several years, and we were going to put in left-sided valves, your oncologist or whoever might say, yeah, fine, no problem. It would be very, very rare to have a recurrence in that area. But it definitely would be a multidisciplinary conversation.
All right, great. Another question here is, can you place the valves in just one lung?
That's exactly what we do. Yeah, so I might not have made it clear earlier, but there's a whole host of factors, but the evidence that we have that on the amount of improvement that you get is all based on unilateral placement, meaning that we only put the valves on one side, and that's what we're expecting to get the result from. So yes, we only put them on one side.
All right, great. The next question here, let's see. How do they test for a nickel allergy? Are the valves made out of a different material?
So the valves are made of titanium and nickel, and generally, which is some people are allergic to the nickel component. It's pretty rare. I usually ask a couple of questions. Are you a very allergic person? Meaning, have you ever had hives or skin sensitivity to things? And especially in women, a lot of times you can ask them, have you ever reacted to costume jewelry? So if you wear a bangle that's, kind of not of gold or silver and you have the rash, then I would definitely want to send you for nickel testing or metal testing with a certified allergist. And they can just do what's called patch testing. So they put different things on your skin and just tape them on, and then attach them somehow, and then they see if you react. And if you have a nickel allergy, then obviously these valves any valve would not be right for you. We would not want to implant those. However, nickel allergies are really rare. So, most women are pretty easy to figure out with the costume jewelry question. Men, a little harder because they don't wear as much costume jewelry. But if someone says, yeah, I have, a lot of dermatitis, or I have skin allergies or general allergies, I'll just go have them tested with the allergist.
All right, great, thank you. Another question here is, what happens to the deflated lung tissues and cells?
Oh, that's a really good question. So what I will tell you doesn't happen, because I have had a patient ask me if the lung would die. That part of the lung would die, and it doesn't. It still has the same blood supply. It's just compressed. We see compressed lung in patients or people all the time. It's called atelectasis, in fact. And those patients, go about their day and live their lives and no problem. So the blood supply should be fairly preserved, although there are shunting mechanisms. Again, everything's more complicated than what it might seem on the outset, but it stays alive. It's just out of the way, and it doesn't work, but it didn't work to begin with.
Thank you. We have time for a couple more questions here. This one is, how long does the procedure usually take?
That's a great question as well. So I've had procedures that were as short as 20 minutes and ones that were as long as about 45. I'd say that's probably the range. Now, when you go into the procedure, of course, you spend more time getting ready for the procedure and more time being monitored after the procedure a lot of times than you actually do in the procedure. So it's probably a full half day, I'd say, process. And then you go into the hospital for 3 days.
Thank you.
You're welcome.
We're going to have a couple more questions here. This one is, I have roughly 30 to 35% lung function. What type of improvement in function can a person generally expect?
Yeah, so that's a great question. So, we've seen patients who in the clinical trials, again, the most clean, ideal patients, the ones who weren't in that wiggle room area, I would say 25% would not be a bad expectation to have on average. That's about what I tell my patients. It's a little different when you're looking at, well, how am I going to improve on the FEV1, which is that number that I talked about with the pulmonary function study. That's how pulmonologists measure COPD lung function for the most part, although there are other ways to do it. How am I going to improve with my walk distance? How am I going to improve with how I feel? A lot of times that subjective feeling is what patients really pay attention to. They don't say to themselves on a general day-to-day basis, wow, I'm walking my 6-minute walk test, 30% more than I did before the procedure. Though that's what I look at. The patients are like, hey, doc, I feel 40% better. I've had patients come in and say they felt, that it was dramatic, and some that come in and say, yeah, I definitely can take deeper breaths. I'm starting to be able to manage my breathing rate a little bit better. And for them, that's good enough. So it's all over the board, but.
Great, thank you. I think that about wraps it up for us on questions today. Thank you everyone who submitted them. We also have been answering them as well. So hopefully you got your answers that you needed. Travis, if you could go ahead and share the screen again so we can wrap up here. And I just want to pass it over to you, Dr. Kopis, if there's anything else you wanted to say before we get kind of to the end.
No, I just wanted to say thank you. And again, check out that website and contact one of your a pulmonary, an interventional pulmonologist who does this procedure near you. And if you have any other questions, I'm sure on their website, they can also be contacted. It's a great website. Did you give him the name of that website? My Lungs, My Health?
Oh yeah, My Lungs, My Life, which will also put it into the chat.
My Lungs, My Life. That's what
My
it is.
Life.
Yeah.
You can visit that. That's also where
There
the
you go.
locator is found. And also there is the phone number, which we also have in the chat as well. And so I just want to let everybody know that if you do go to the website, there's plenty of helpful information on there. We have videos, we have other webinars, we also have articles. You can really find a lot of helpful information to support this. You'll be receiving an email from us as well to help you, guide you along your journey. And we just want to say thank you so much for joining us today, and we hope it was helpful to you.